I'm honored to introduce Dr. Claire Tempany Abdel. She's a professor of radiology at Harvard Medical School, and she's leading a Center for Image-Guided Therapy at Women's and Brigham and Women's Hospital in Harvard as well. Dr. Tempany will focus on a very specific high-end application of MRI, image-guided therapy, with focus on prostate cancer.
Thank you very much indeed to the AMPC for this incredible honor. I'm delighted to be here and share the work of many people at our center and beyond. I was going to cheat a little bit. I was asked to do a case study. I'm going to do 2 case studies, so apologies for that in advance. Some financial interest to declare. Really going to try to cover 2 major advances that have occurred in prostate cancer diagnosis and treatment, looking at some interventional systems, the biopsy program, and focal therapy. We'll touch on, of course, the clinical needs that drive this, the background of both of these programs, the techniques, and of course, cost effectiveness. The background to this is the image-guided therapy program at the Brigham and Women's Hospital, established by Frank Ulez back in the early 1990s, when the very first MRI scanner was placed in an operating room, the so-called MRT system, or Cigna SP, operating at 0.5 Tesla, was placed into an operating room in collaboration with Frank and General Electric. And you can see this, which lived in the Brigham Hospital and multiple other hospitals in the early 1990s. We developed an enormous number of exciting programs from that, which were translated into the current version, which is called Amigo. Before we get there, obviously just a couple of years after that, the very first MR-guided focused ultrasound clinical program was established at the Brigham through, again, the leadership of Frank Ulez, Kalervo Hinnanen, Maury Blumenfeld, and others at General Electric. The focused ultrasound program has taken off, and I'll follow that history for you as well later on. So these are the 2 areas of interest. A very important milestone for us was achieving NIH support for the National Center for Image-Guided Therapy in 2005, which then in 2011 allowed us to establish a physical translational research space known as AMIGO, which stands for Advanced Multimodal Image-Guided Operating Room. We're now not exclusively focused on MR-guided interventions. This obviously has a PET-CT scanner, has multiple other imaging systems such as 3D ultrasound, mass spectrometry, fluoroscopy, and angiography, and we'll show pictures of that in a minute. Some of the major milestones, just to hit on them, because I don't have time to talk about everything today, but the first human vaccine injection into a brain tumor was performed by Nino Chioca, the neurosurgery department at the Brigham just last year, and this was done under MRI guidance. We're doing MR-guided lung and breast cancer surgeries, both of which have been so successful. They've now transferred out to hybrid ORs, which are very popular across the operating rooms, physical plants of the world now. Both of these very successful programs for resecting both lung cancers and breast cancer. A very important one to highlight, which correlates nicely with the mass spectrometry data that, mass spectroscopy data that you just saw. One of the most exciting things that we're doing in the operating room is the real-time acquisition of mass spectrometry data to evaluate the 2-HG metabolite in brain tumors. And this is now guiding glioma surgery in an attempt to reduce the recurrence and the positive surgical margin. So this is the opening day of the Amigo, and several of our friends from the NIH, of course, and Frank, and our hospital administrators were there. The purpose of this space, as I said, is a clinical testbed space. Everything in it is done in humans only, all patients for precise localization of tumors and boundaries for therapy. Just a very quick snapshot of the types of cases that are being done in this space. Since it opened 7 years ago now, a little over 1,800 cases, a lot of interventional radiology, image-guided procedures, be they ablations or biopsies, arterial chemoembolization, big area in neurosurgery, obviously, and then in radiation oncology as well, with image guidance there. So the prostate program itself has grown in parallel to all of these developments. We started back in the late 1990s, when we established an MR-guided brachytherapy program for prostate cancer treatment. Anthony D'Amico, a radiation oncologist, and myself started placing these little I-121 sources into the prostate to treat prostate cancer under MRI guidance here with the patient in a lithotomy position and a transperineal approach. From that program grew our MR-guided prostate biopsy program. Clearly, if you can put in a bunch of radiation seeds, you can take out small cores of tissue. So it was very simple to do this in gantry biopsy with a transperineal approach as well. In parallel, again, with the focused ultrasound program, we developed a preclinical program here, not in the Amigo space, but in a separate area. With Nathan McDonald and I, we did a preclinical canine model study funded by the NIH, which led to the development of the clinical device that's currently in clinical trials, which I'll conclude the talk with and show you some example of that in clinical trial today. First ever multi-center trial in focal therapy and prostate cancer in the US is ongoing, having been developed in this space. The other things I've mentioned already, the other things we do in prostate cancer, of course, are ablations with cryotherapy as well. So really, this is the journey that I'm trying to share with you today, is the journey from added science and to added value, clearly working through a lot of the new MRI techniques in prostate cancer that we'll touch on in a minute, interventional devices with moving from 1.5 to 3 Tesla, multiple minor adaptations in technique as we went along, many different pulse sequences in development and hopefully hyperpolarized as well at some point soon. We are working on improving the diagnosis, characterization, and detection of clinical significant prostate cancer, which then allows us with a really robust roadmap to do and deliver effective focal therapy. So let's just take a little detour for a minute and talk about what about prostate cancer, the facts of the disease today in 2018. This is still the current standard of workup of a typical patient who presents for assessment of possible prostate cancer. Most patients will still, before a biopsy, have a digital rectal examination and a PSA drawn. Now, the digital rectal is entirely subjective and particularly useless in detecting prostate cancer. But the PSA, which is a little bit more than useless, is actually quite useful. When you look at the range of normals by age and specific race, PSA is a definite help. It's gotten into great debate and discussion over the last decade or so, with the US Preventative Task Force assigning it a grade D, which is very bad, and then moving it up to a C, which is a little bit better, but it's still not a good grade. As you know with your kids, a C is okay, but not great. So it means that it's not really widespreadly recommended for screening. So the big problem still remains, what can we do for screening? And I'm hoping I'm going to convince you that you and all of us have now reached the conclusion that MRI is the way to go for that. But today, still, most centers will refer a patient, if these two are abnormal, one or both, for a transrectal ultrasound-guided biopsy, which is a needle placed into the prostate under ultrasound-only guidance. And the ultrasound is simply showing where the prostate gland is. A systematic sampling, and that means sampling right, left, base, apex, mid, in a very uniform pattern of core removal, is what's typically done with anywhere from 6 to 12 cores of tissue taken out per session. Pathology, of course, is then the ultimate, where it's analyzed in the determination of cancer. And just a little bit more on facts, it's actually decreasing in numbers slightly. It's down to 164,000 new cases per year. Most present early. Few men die of this, but a significant number do die, but 30,000. So big difference between the number of cases and the number of deaths. It really has a disease-specific mortality of only 4 to 8%. And that's a really important fact to remember. So standard of care is still really problematic. The ultrasound-guided biopsy will miss 30 to 40% of cancers and will misclassify, in other words, end up with the wrong Gleason grade being assigned in about 25%. So we have this huge problem of overdiagnosis and overtreatment. It's facing a huge societal impact. Today, in 2012, over 11 billion was the healthcare cost. If we look at the numbers and the way it's growing, by the year 2021, it will grow by 42%. So we're going to have a hugely increasing health cost to society. So we have to really try to rein this in a little bit. And a smarter biopsy has pretty much been determined by almost everybody to be the way to try to go and determine who needs treatment. And following Petra Huppy's excellent example of a patient story, I thought I would sneak in my story of John, who is a 61-year-old man who is a chemical plant manager, who presented back in the year 2000 to his primary care physician for an annual examination, which at that time, and still does pretty much, include a history, physical, and some testing. The testing included a PSA measurement, which came back at 12. And I just told you that 4 is the upper limit of normal, so this is clearly very abnormal. He was immediately referred for a prostate biopsy. And we're going to come back to him in the minute. I want to just deviate a little bit for a second and talk to you about the MRI technical developments that have occurred over the time that I've been involved in prostate MRI imaging. not trying not to give away my age too much, but going back in time a little bit to when I was at Johns Hopkins, we started doing prostate MRI with a body coil and 1.5 Tesla imaging. We moved on to endorectal coil at 1.5 Tesla imaging, which also provided much more exquisite imaging of the capsule. In those days, we were primarily looking at the stage of the prostate cancer. Was it growing outside the prostate? Today, we now have multiplanar T2 protocols with diffusion-weighted imaging and dynamic contrast-weighted imaging. Along the way, multiple multi-center trials were performed, and I'm just illustrating a few of them. Started off with an RDOG trial, Akron trial of spectroscopy, Akron trial of test-retest, very important for the quantitative metric assessment. And then we've ended up not with a trial, but a really good guideline set now known as PIRADS V2. And so just wanted to show you also the ARC. The New England Journal of Medicine doesn't publish a lot of MRI papers, but these two very important ones from 1990 to 92 to just 2 months ago, 2018, really show you how things have developed. This was the first one that came out of that RDOG study, staging study, which said that MRI and ultrasound were equally good for staging. So that really stalled the development of MRI for a while. And then really fast forward to this fantastic trial, which just was published this year, the Precision trial, a multi-center, randomized, multinational trial of men demonstrating really, I think, finally, without any doubt, that MR targeting works very well and much better than standard truss-guided biopsy for diagnosis of prostate cancer. So back to John again, his PSA, as you know, is now 12. He goes for a biopsy. This is the approach that happens. And of course, all cores at this point, unfortunately, came back negative. We're going to come back to him again. The story goes on. So here's the PIRADS set of MRI sequences that are typical for diagnostic MRI today, not terribly fancy and sophisticated. We basically have T2, diffusion, and ADC, and really in order of importance, it's the diffusion. And the diffusion is the critically important sequence, and here you see the raw B and the ADC. B values of about 1,400 or higher are all recommended for everybody. Let's look at this amazing growth of publications. Last year, we peaked at nearly 900 publications on prostate MRI alone. That's a huge number. I personally can't keep up with reading them all, but this has become an incredibly interesting space with everybody getting involved, which is incredibly gratifying. So remember, our patient is sitting down here where the data wasn't very good. So remember that from his story. So he comes back again. Now his PSA has gone to 14 in December of 2000. Another round of biopsies, nothing found. Fast forward, he's now going over a 2-year period of time. His PSA is going from 13 to 15 to 14 to now 21. And this is really disturbing. His prostate-specific antigen has now become a source of patient-stimulated anxiety. It was always that from the beginning, but this poor man is now looking at 21 over 2 years, still no diagnosis of cancer. He can't be treated yet. So if we summarize his story, you can see again the plots and the number of biopsies he's had. He's had a total of 4 sessions of biopsies. That means at least 48 cores have been taken out of this gland, none of which found his cancer. So finally, you're all saying, why didn't it happen sooner? He had an MRI examination. It showed a 2-centimeter lesion on the right side. It was biopsied by us in bore, came back as a significant Gleason, went to surgery, and luckily, even though he had a big tumor, it was confined and there was no extracapsular extension. So a good ending to a long and traumatic story for him. And then this nice schema really demonstrates what was happening in all of those biopsy sessions. All the needles were coming in from posteriorly here, and they were all missing the lesions all the time. And you're just random sampling, you're not going to find the significant lesions. So just to tell you a little bit of the background of the ADC and the diffusion, because this is really an inflection point in prostate MRI. And this is some of the early work, and wanted to cite these 3 papers, which all really started to show us the power of ADC quantitatively as an in vivo biomarker to correlate with Gleason grade. So the ADC value itself is inversely related to the Gleason. The lower the ADC, the higher the Gleason. The higher the Gleason, the more significant the disease, the more likely it may kill that patient, the more important and the more likely that patient needs active treatment. So you can see this work here, and then work from Baris Turkby and others, and Tom Hambrock and others, all showing the same thing, getting better and better with every paper, and there have been hundreds of these papers since. These 2 images illustrate very nicely 2 different patients, very extreme disease here, no disease here. The ADC is 600 here, the ADC is 1,500 here, and you see the corresponding Gleason scores. So PIRADS was established first of all by the Europeans in 2012 to help us image, report, and collect data in a formal way for MRI-guided biopsies. And this was really the step towards improving the quality of all of these biopsies. And you see here the people that have been involved in this, from the V1 to the V2. V2 is now the standard, published in this article by Weinreb et al. So PIRADS fulfills all of these needs, which are terribly important for us, provides a roadmap for us, or the surgeons, whoever's doing a biopsy, so they can actually determine where to sample. And just a brief story about our own personal one to highlight 3 of the important players back in the beginning of our MR-guided interventional program in the MRT and now in AMIGO, and some of our funding. And it's very gratifying to see, but it does take time, about 20 years, for this to become an established clinical approach, which is really important. And this is how we do it, where we sample it now in the bore of the magnet transperineally, allowing site-specific pathology to be acquired. We've correlated that with pulse sequences. I'm going to speed up just a little bit because I want to get to focused ultrasound. We're also developing technologies for robotics and enabling techniques to reach inside the bore of the magnet. Many different devices are being developed for that. There are multiple biopsy approaches today. So there's those in-bore or in-gantry, out-of-bore, out-of-gantry. There are fusion biopsies, cognitive, template, and saturation. A nice summary paper here from the UCL group. And these are some pictures of some of those systems now that are all commercially available. So this has really made the big time now when you know that lots of companies are making these fusion systems or enabling devices to work inside the bore of the magnet. The fusion systems acquire an MRI beforehand, a month, a week before the biopsy, and then register that on the day to a real-time ultrasound exam, which this little video clip is trying to give you a feeling for. And so that you can see that there are differences, the way the ultrasound sees prostate boundaries and before MRI sees it. So they have to be warped together, and that's what each of these is doing in slightly different ways. So good systems, some of the recent highlights I've already mentioned, the PROMISE paper and the PRECISION paper, really important papers. If you read just one, go read this one when you go home. The other high-value thing that's being delivered is the biparametric. Now we're hoping to be able to remove potentially the intravenous gadolinium contrast, and you've heard about this work at this meeting this week, and previously from Christiana Kuhl, Ivan Jambor, and Bozen et al., showing us that biparametric really works. So a new day really has dawned, a major change in clinical practice, already accepted in clinical practice in the UK and Australia. I'm not sure about the tomorrow in the US. We're a little bit slower than the rest of the world sometimes, much slower, to adapt some of these newer techniques. Cost effectiveness. There have been multiple papers that demonstrate this is a cost-effective approach to the diagnosis of prostate cancer because you will reduce the number of biopsies you do. Multiple papers showing this, and one from our group as well, showing the cost effectiveness and the ICER ratios, that you save money by doing an MR-guided biopsy on less people than all people having ultrasound-guided. And just to finish up, I want to touch on MR-guided focused ultrasound surgery, an area of great interest of ours, which also has been a very high-tech approach, a disruptive technology, putting an MRI treatment system into a diagnostic magnet. Just to give you a snapshot of what's available on the Focused Ultrasound Foundation website, there are about now 90 indications for the use of MR-guided or ultrasound-guided HIFU or focused ultrasound in development. And this is a very nice chart where you see it going from concept to reimbursement. And there are about 14 companies now in this space. So this is definitely not something that is not being translated well. Ultrasound-guided prostate cancer therapy started with HIFU back in 1995, the first trials in Europe, and they were treating the whole gland non-focally. Transurethral program is in clinical trials currently with a company called Profound using the Tulsa Pro, which is a transurethral transducer arrangement treating the whole prostate. There are multiple trials, some of which have already been published, demonstrating the effectiveness of that. The Insight Tech device that I mentioned earlier is now in clinical trial as well, allows for focal ablation, as you can see here in the animal model research. And then this is my last slide, just demonstrating the overview of what we're doing in a clinical trial today, led by the Memorial Sloan Kettering Group and all of these other sites, using MRI to treat small subregions of the prostate, as defined with the MRI techniques developed by all of you and many others in defining the actual lesion using diffusion or ADC and T2-weighted images, and then here's the transrectal probe, and then immediately after the treatment, a gadolinium injection demonstrating the non-perfusion and hopefully necrosis. So in summary, I really want you to appreciate, I hope, that high-end MRIs and added science does lead to high value for patient care. MR and image-guided therapies are here to stay. Operating rooms are putting in imaging systems all over the world, about 5 million hits on Google yesterday. IMRIS, the company led by Greg Sorensen now, is installed or is pending installing 68 sites in the world. Some of these, a little take-home message for those of you who are starting out in your journey of translating your research into the clinic. It's a long journey. Enjoy it. It takes some stamina and real persistence. One of the most important things is to work as a team. I have to say that I really am so happy to be a member of the International Prostate Working Group and the PIRADS team, who've all become friends and supporters and people who do different work and contribute together to move the field along. And of course, collaborators outside radiology are critically important. As you all know, and this is speaking to the converted, we all know that we have to do good studies, we have to collect our data. Look at costs and charges as you go, very important. Talk to your patients, get their input on this, and you really will be able to demonstrate real value. Hopefully, eventually, we'll get to a diagnosis and treat paradigm for prostate. I think you heard a little bit about that nice idea of point of care, very well illustrated in a plenary earlier this week. Thanks to the home team, and thanks to the technologists, nurses, and folks that we work with in the operating room. And again, many thanks to the PIRADS people who've really become great friends and some sources of information for those of you who are active on Twitter. MRI First is a good handle, MPMRI is another one, and PIRADS as well. But there's something on there every day. So thank you very much indeed for your attention.